Hey, hello everyone. It's a great honor for me to share our research project in this conference. Today, I'm going to talk about the management of arterial blood pressure through multimodality monitoring during cardiopulmonary bypass surgery. All these experiments actually were done in Johns Hopkins Hospital in the United States. So as we all know, cardiovascular disease are the #1 cause of death globally. More people die annually from cardiovascular disease than from any other cause. An estimated 17.9 million people died from cardiovascular disease each year, representing 31% of all global deaths. And of all these deaths, 85% are due to heart attack and stroke. In the United States, around 50% of the adults have cardiovascular disease, and demand for cardiovascular surgery is expected to increase gradually, along with a rapid increase in cardiovascular disease with respect to the aging population. So cardio bypass surgery is actually used to improve blood flow to the heart. A surgeon uses blood vessels taken from another area of the body to bypass the damaged arteries. Most patients may be hooked up to a cardiopulmonary bypass machine that circulates oxygenated blood through the body while surgeon operates on the heart. And in the United States, each year, doctors perform around 200,000 such surgeries. So in cardiac bypass surgery, the doctors often want to decrease the blood flow as lower as possible, because this can help the doctor reduce bleeding from collateral circulation and give a clear vision for the surgery. However, decreased cerebral perfusion is especially important during cardiopulmonary bypass surgery, associated with major morbidity and mortality, acute kidney injury, and delirium. Take AKI, acute kidney injury, for example. It affects around 30 to 50% of patients after cardiac surgery. Efforts have been made to improve the outcome. And Christoph and Cambridge from Houston have done some very interesting experiments related to the brain and the kidney. Current hemodynamic management lacks the input of an end organ monitoring strategy to assess the adequacy of perfusion for individual subjects. And regional splenic arteries, including renal vasculature, are the most common vascular beds compromised during low flow states. So Christopher and Cambridge did this experiment in in the piglets, in 10 small neonatal piglets. They extract the blood flow from a femoral artery continuously to simulate the hemorrhagic shock. And as we know, in healthy patients or in healthy people, pressure articulation protects vital organs during transient changes in arterial blood pressure from diminished or excessive blood flow over a range of blood pressure. However, we don't know in this kind of hemorrhagic shock situation, what happens to the brain, what happens to the kidney, which organ fails first. So Christoph and Ken, they put a laser Doppler in the brain and in the kidney to monitor blood flow of these two organs during this hemorrhagic shock. And then, interestingly, they found for the brain, decrements in cerebral blood flow to 75%, 50%, and 25% of baseline occurred at 30, 25, and 15 millimeter of mercury, respectively. However, in contrast, for the kidney, decrements in renal blood flow to 75%, 50%, and 25% of baseline occurred at 60, 50, and 45 millimeter of mercury. which means renal blood flow is impaired during hemorrhagic shock in advance of any disturbance to cerebral blood flow and before clinically significant reductions in arterial blood pressure. And also, we can see the autocoagulation ability of kidney disappears first than the cerebral autocoagulation. So then here we may need to mention one function of the brain, which is cerebral autocoagulation. It refers to the ability of the brain to maintain constant cerebral blood flow over wide changes in arterial blood pressure. And as we know, like it's like in this lesson curve. So if the blood pressure is between these two limits, and then the brain blood flow can be kept stable. However, if the blood pressure drops below lower limit of autocoagulation, we can see there is a linear relationship between blood pressure and cerebral blood flow. And then this means the brain compensatory mechanisms are inadequate and the cerebral blood flow decreases in parallel with arterial blood pressure. Therefore, maintaining arterial blood pressure above this lower limit of autocoagulation is extremely important, especially during cardiopulmonary bypass surgery. Cerebral autocoagulation can be assessed in real time in patients by comparing spontaneous changes in cerebral blood flow in response to changes in arterial blood pressure. So like using multimodality monitoring such as NIRS or TCD, transcranial Doppler, we can calculate a moving correlation coefficient between blood flow and arterial blood pressure. Thus, we can calculate autocoagulation and assess cerebral autocoagulation. If this correlation coefficient is very big, it's near 1, this means passive relationship between arterial blood pressure and cerebral blood flow, which means impaired autocoagulation. If the correlation coefficient is smaller, like negative or 0, it means good autocoagulation. It means active cerebral vasculature. So we can monitor cerebral blood flow through NIRS, which renders the index of COX, which is a correlation coefficient between arterial blood pressure and regional cortical oxygen saturation. We can also monitor cerebral autocoagulation through TCD by calculating the correlation coefficient between arterial blood pressure and cerebral blood flow velocity. We call this parameter as MX, mean flow index. So in our ICU and in our operating room, we continuously and simultaneously monitor arterial blood pressure, cerebral blood flow, and oxygen saturation. And then so that we can calculate MX and COX at the same time. However, if we have these recordings, and if we put COX in y-axis, and then if we put arterial blood pressure in x-axis, we can normally get this kind of U-shaped curve. As we know, like bigger COX means bad autocoagulation, smaller COX means good autocoagulation. So in this U-shaped curve, we can find the best autocoagulation is located at this lowest point. So if we find this arterial blood pressure, we call this arterial blood pressure as optimal arterial blood pressure, individualized optimal arterial blood pressure, because it means at this level of blood pressure, the brain reaches its best autocoagulation ability. And we have done some early experiment. We used 230 cardiac bypass patients, and we use this like U-shaped curve. So no, like we create this Lassen curve for each patient. We put like TCD, cerebral blood flow velocity, or nears oxygen saturation in the y-axis, and we put mean arterial pressure in x-axis, and then we can find this lower limit of articulation for each patient, and then accordingly we can define which threshold is the best to locate the lower limit of articulation for each patient. And our result told us like COX of 0.35 and MX of 0.45 can be the best threshold to define lower limit of articulation. In this case, with this method, we then can calculate or can define lower limit of articulation for each patient. And then for the next step is that we want to say whether like the lower blood pressure can cause acute kidney injury during cardiac bypass surgery. So our colleague, Professor Charles Hughes, has done this experiment with 348 cardiac bypass patients. So among all these patients, 121 got acute kidney injury afterward, defined by the rifle criteria, and then which means like 35% of this cohort got acute kidney injury after the cardiac bypass patient and bypass surgery. And then he defined, using the method we mentioned previously, he defined this lower limit of articulation for each patient, and then calculated the area of blood pressure under this lower limit of articulation for each patient. Which means like we calculate the product of the magnitude and the duration as this area of ABP below LLA. And then the results show that for acute kidney injury, diabetes and congestive heart failure are risky parameters for acute kidney injury. And interestingly, we found for the patient who got AKI after the surgery, they experience longer and like larger magnitude of blood pressure below lower limit of articulation, which means like the patient with AKI actually experience larger like and longer hypotension during surgery. So this result told us that maintaining arterial blood pressure above the real-time determined lower limit of articulation may be an effective strategy for reducing AKI after cardiac surgery. Next, we looked at like delirium, because delirium is very common after cardiac surgery. It affects around 50% of patients, and delirium places a large burden to the healthcare system due to the prolonged hospital stay related to extensive workup patients undergo and treatment once the causes have been recognized. Also, in patients admitted with delirium, 11 to 26% had a mortality outcome, and patients who develop delirium during their admission have a mortality between 22 to 76%. And here is the example of delirium. It's really place a big burden to the nurses, doctors, and the hospitals.
I want to get out of here. Mr. Williams. You're keeping me. I don't want to stay here. Mr. Williams, I'm the nurse practitioner. Barb, remember me from yesterday? No, I don't. You're in the hospital. Get me out of here. Let me get your glasses for you.
You see this patient, he is like resistant to the medical care. He doesn't recognize any people and he's really aggressive. So this delirium places a large burden to the medical health system. We want to change this outcome. So like my mentor, Dr. Charles Brown, have done this analysis. Is actually a clinical trial. So they got like 200, around 200, so 199 patients in total, and they were divided into two groups. One is like control group, who were treated as like a normal procedure. So which means that during the cardiac bypass patient surgery, the patient's mean blood pressure was kept above like 60 millimeter of mercury. For the LLA group, or like experimental group, the patient's MAP was like kept above their individualized LLA, lower limit of articulation. So which means we actually define LLA first before for each patient before their cardiac surgery, and then during the whole cardiac bypass surgery, the doctor will keep this patient's blood pressure above his own LLA. And then let's have a look at the result. So we can see for the standard group, which is like the group, the control group, they had a much higher delirium incidence than the experimental group who were treated with LLA, like a LLA target. And the number of days of delirium was greater in the standard group compared with articulation group. So this paper suggests that optimizing mean arterial blood pressure to be greater than an individual patient's lower limit of articulation during cardiac bypass bypass surgery may reduce the incidence of postoperative delirium. And one of our colleague, Dr. Ona, he performed another analysis related to major morbidity and operative mortality. So in his study, he included the endpoint as operative death, stroke, renal failure, mechanical lung ventilation, or low cardiac output syndrome. And then among the 437 patients, 83 of them developed MMOM. And then he calculated using the method we mentioned previously. He also calculated the AUC area of mean arterial blood pressure under the lower limit of articulation for each patient. And then here is the result. We can see for the group with MMOM experienced much larger extent of blood flow lower than LLA, comparing with the group without MMOM. So, and then we talk about LLA because in cardiac bypass patient, as we mentioned, doctor want to decrease the blood flow as lower as possible. However, they also using the CORCS or MX, we can also define optimal ABP as a target. So which one is better, optimal ABP or LLA for cardiac bypass patient? We don't know. Therefore, we performed the study. We used 231 cardiac bypass patients data, and then we compared MAP optimal mean arterial blood pressure and LLA to see which one is much more related to clinical outcome. And then here are the results. So our results show that MAP below LA was more strongly associated with AKI and MMOM than MAP below MAP optimal. In other words, LLA appears to be the more clinically relevant threshold for cardiac bypass surgery. And then we developed a visualization tool. I think this is a very interesting tool. So we examined the contribution of lower magnitude pressure versus duration in the calculation of AUC of MAP below LLA. So we put like duration in y-axis and then the magnitude of MAP below LLA as x-axis, and then they color is a possibility of patient develop MMOM or AKI. So red means high probability and blue means low probability. So take this line, for example, this point means like if the patient have a lower map below LLA by 13 millimeter of mercury, and if he stayed in this low map for longer than like 30 minutes, and then the probability of getting MMOM after the surgery will be 50%. And similarly, for example, here, this means like if the patient blood during the cardiac bypass surgery, if the patient's blood pressure is lower than LLA by 13 millimeter of mercury, and if it lasted for like 30 minutes, and the patient got the probability of the patient getting AKI after surgery will be 40%. And from these two graphs, we can see the longer the duration, the longer the hypertension is, and the higher of the probability of this patient getting MMOM or AKI after the surgery. We can also see the influence of the surgery duration and the baseline RSO2. So the longer the bypass surgery duration is, like longer bypass surgery will cause like higher probability of MMOM or AKI after surgery. And also like less RSO2 will increase the probability of getting MMOM and AKI. So therefore, we know the lower limit of articulation can be affected by many conditions that result from vascular disease, including hypertension, previous stroke, diabetes, congestive heart, etc., etc. Because these conditions have widespread pathophysiologic consequences, it is logical that other organs, in addition to the brain, might require higher blood pressure to ensure organ perfusion during cardiac pulmonary bypass surgery in affected patients. More importantly, the previous findings suggest that maintaining mean arterial blood pressure within the articulatory range for the brain will ensure perfusion to other organs, particularly the kidney, whose blood flow is also articulated. I would like to thank all my group members and my mentors in Johns Hopkins, and thank you so much. And like hopefully you enjoy the talk, and please feel free to ask me any questions or through the email. Thank you.
Hello everybody, my name is Danilo Cardim and I am a researcher at University of Texas Southwestern Medical Center in Dallas, United States. And today is my great pleasure to speak about this theme, the brain-eye crosstalk, a window for non-invasive assessment of intracranial pressure. And in this talk, I will discuss the optic nerve sheath diameter approach for the non-invasive assessment of intracranial pressure, highlighting the advantages and pitfalls of this technique in the context of neurotrauma clinical conditions such as traumatic brain injury, as well as non-neurotrauma related pathologies. So to start with, some background about intracranial pressure monitoring. As we know, elevated intracranial pressure is an important cause of secondary brain injury, and this is associated with poor patient outcome. So for example, in most cases of acute neurological diseases, one example being traumatic brain injury, elevated intracranial pressure requires active management of the patient. And unfortunately, this cannot be done without direct measurement of the intracranial pressure. And the gold standard to monitor intracranial pressure at the current clinical practice is through invasive monitors, which increase the risk of infection and hemorrhage to the patient. So for example, in these two figures, we have CT scan images showing hematoma regions caused by the insertion of ICP sensors in the brain cortex. So for example, here we see the tip of the probe causing this hematoma region in the brain cortex. as well as visualized here in the second figure. But also, there are situations, despite the importance of intracranial pressure monitoring, there are situations in which invasive ICP monitoring is not indicated, but it would be extremely important to monitor it. So in these cases, non-invasive ICP sensors would be highly desirable. However, the non-invasive assessment of intracranial pressure still consists of mostly exploratory techniques, where several techniques have been proposed in the scientific literature to estimate ICP non-invasively, which is the topic of the next slide. So regarding the non-invasive assessment of intracranial pressure, here I will discuss some of the methods that take advantage of the so-called brain-eye crosstalk. So here in this figure, we have one of the techniques based on a 2-depth high-resolution transcranial Doppler ultrasonography insonation of the ophthalmic artery. So in this method, the intracranial segment of the ophthalmic artery is compressed by ICP intracranially. And then the extracranial segment can be compressed by pressure that can be applied externally through a compressing device, as is shown here in the figure. Which is transferred, this pressure is transferred into the orbit without pressure gradient, as the orbital tissues are incompressible. So for this method, TCD can be transcranial Doppler insonation can simultaneously measure cerebral blood flow velocities both in the intracranial and in the extracranial segments of the ophthalmic artery during the application of a series of, for example, small pressure steps to the tissue surrounding the eyeball, as we can see here in the figure. So finally, when the pulsatility of the cerebral blood flow velocity measured with transcranial Doppler in the intracranial and extracranial segments of the ophthalmic artery are approximately the same, the external pressure applied through the device equals the intracranial pressure in the intracranial compartment. And another method that takes advantage of the brain-eye crosstalk is the so-called optic nerve sheath diameter measurement method. So this method has emerged in the literature as one of the most viable, practical, and least complex methods to assess intracranial pressure non-invasively. So for this method, the brain-eye crosstalk as means for non-invasive assessment of intracranial pressure is only possible because of the anatomical continuation of the subarachnoid space from the intracranial to the extracranial compartments of the head. And we will see this how this method is possible in more details in the next slide. So in this figure, which represents the cerebral spinal fluid circulation, we can observe that the optic nerve located extracranially is surrounded by the subarachnoid space, where the cerebrospinal fluid, here represented in blue, can circulate freely. And because the intraorbital part of the subarachnoid space contains distensible structures, it can expand when the cerebrospinal fluid pressure, which is equivalent to the intracranial pressure in the brain tissue, increases during, for example, events of increased intracranial pressure. As such, this increased pressure, the intracranial pressure, can be detected, for example, using techniques of ultrasonography or magnetic resonance imaging of the eye globe when there is, for example, an enlargement of the optic nerve sheath measured during these events of intracranial pressure. And this relationship actually forms the physiological basis for using the optic nerve sheath diameter as a surrogate for intracranial pressure measurement. So magnetic resonance imaging is one of the potential techniques that can be utilized to measure the optic nerve sheath diameter. So clinically, MRI is often performed in patients at risk for increased intracranial pressure. And this technique can be used to measure precisely the diameter of the optic nerve and its sheath, as we can see here in this figure. Um, most studies using MRI assess the relationship between the optic nerve sheath diameter as measured with MRI and intracranial pressure measured invasively to derive models that could predict the value of intracranial pressure based on MRI measurements. So for example, this is a study by Thomas Geertz and collaborators investigated the relationship between optic nerve sheath diameter and intracranial pressure. So in this case, optic nerve sheath diameter was measured through magnetic resonance imaging, and the authors observed a strong and significant relationship between the optic nerve sheath diameter measurement and the values of intracranial pressure measured invasively. And they also performed another analysis to determine which threshold would be best to predict events of intracranial hypertension, that is, increases of intracranial pressure above 20 millimeters of mercury. So for this study specifically, they found that a threshold cutoff of 5.8 millimeters for the optic nerve sheath diameter um, had an area under the curve of 0.94 and had high sensitivity, specificity, and negative predicted value to predict events of intracranial pressure above 20 millimeters of mercury based on this threshold of 5.8 millimeters. And also another study by Secon and collaborators investigated the relationship between optic nerve sheath diameter measured through MRI images and intracranial pressure measured invasively. And the authors found a significant, strong relationship between these two parameters. So considering these two studies together, we could suggest that, for example, when brain MRI is indicated, the optic nerve sheath diameter measurement based on images obtained during, for example, clinical routine sequences could provide a quantitative estimate of, for example, the likelihood of significant intracranial hypertension in TBI patients. So despite the benefits and precise measurements of MRI, we know that this technique is very expensive and most of the times not readily available in most hospitals worldwide. And the question that I raise here is, can we visualize and measure the optic nerve sheath diameter with a simpler technique such as ultrasound? So for example, compared to MRI, ultrasonography is a simple bedside tool that is widely used, for example, in emergency units in every hospital. And another advantages of ultrasound is that this is a low-cost technique. It's highly available and does not need, for example, long acquisition times in comparison to MRI. As well as it does not require harmful patient transport. And for example, in the literature, measurements with ultrasound seem to have a high reproducibility of measures. So in the literature, we can find that several studies have directly correlated optic nerve sheath measurements with ultrasound compared to ICP measured invasively. And in those cases, ultrasound of the optic nerve sheath diameter appeared to be even superior to morphological changes of the same structure measured with MRI. So now in this part of the presentation, we are going to progress with the more technical aspect on how to perform the ultrasonography measurements of the optic nerve sheath diameter to detect rises in intracranial pressure. So first step for the insunnation. So we will need here an adequate high frequency linear transducer probe using the ocular protocol. We will need insunnation gel applied on the insunnation area. And regarding the position, so in this case, resting the probe hands on a bony structure, for example, the forehead or the brow ridge, stabilizes the image and lowers the risk for inadvertent pressure on the eye globe, which could be detrimental. And also, there should neither be any direct contact of the probe with the eyelid nor extreme pressure exerted on the eye globe. And now, moving on, the second step consists of performing small and subtle movements, scanning from side to side, for example, from the temporal to the nasal areas, slowly angling the probe superiorly or inferiorly to bring the optic nerve into view. And the goal is to center this on the monitor, as we'll see in the next slide. So if the lens or iris is not seen in your image, the image plane is likely off axis, and this may result in an underestimation of the optic nerve sheath diameter. So regarding the insunnation planes, the globe should also be scanned in the parasagittal side, longitudinal cross-section and transverse cross-section, with the probe marker superiorly. And both eyes should be scanned so we can have an average of the optic nerve sheath diameter. So as a good practice, we should always minimize the time spent in active scanning, because the high energy produced by the ultrasound can harm the eye globe. So finally, once we have our images, we should first locate a point that is 3 millimeters posterior to the optic disc, as shown here in this figure. And then, following that, we should place the calipers at 90 degrees to the axis of the optic nerve to measure the diameter of the optic nerve and the optic nerve sheath, as we can see here. And then take the average of 2 or 3 measurements for each eye. So now, regarding the possible technical limitations and pitfalls of this ultrasonography technique, here in this slide we have two images of the same optic nerve in A and B. So in A, the optic nerve sheath, as we can see here, delimited by this gray area, is visualized in the sagittal plane and appears as a sharply defined hypoechoic band, whereas in B, for example, the optic nerve sheath is falsely enlarged by this, as we can see, this shadowing artifacts that is probably caused by the optic disc. So these artifacts, they may be detected by comparing, for example, different pictures of the same optic nerve, or by sliding the probe in the same plane, or, for example, since these artifacts are not well defined as the actual anatomic structure. So by exploring the area a little more, you will be able to define which is the actual anatomical structure and what is actually artifacts. And once we have our measurements of the optic nerve sheath obtained with ultrasonography, we need to bear in mind the normative values for the range of optic nerve sheath diameter. So it's been reported in the literature that adults present as normal values below 5 millimeters. Pediatric patients between the ages of 1 and 15 years old will have optic nerve sheaths below 4.5 millimeters. Infants will have below 4 millimeters, and the threshold for detecting intracranial hypertension above 20 millimeters of mercury has been delimited as 5.0 to 5.7 millimeters. Although the assessment of optic sheath diameter for the detection of intracranial hypertension has been vastly studied in the literature, this method still presents with inconsistent accuracy as most reports have presented different levels of accuracy as we can observe here in this table. So in order to evaluate the overall accuracy of optic sheath diameter, in this work, Raba and collaborators, they performed a meta-analysis to evaluate the diagnostic accuracy of optic sheath diameter measured with ultrasound for the assessment of intracranial hypertension in adult patients. So overall, although the wide 95% confidence interval in the pool diagnostic ratio found in this study suggests caution when utilizing ultrasonographic measurements of optic nerve sheath diameter, Raba's work have suggested that these measurements of optic nerve sheath diameter with ultrasound may be potentially useful approach for assessing increased intracranial pressure, for example, especially when the invasive methods are not indicated or even available. So moving on with the clinical applications of optic nerve sheath diameter measured with ultrasound in both neurocritical care settings as well as non-neurocritical care settings, I would like to start with some selected studies performed by me and some colleagues in TBI patients. So the first example I'd like to highlight is this study published in PLOS Medicine entitled Ultrasound Non-Invasive Measurement of Intracranial Pressure in Neurointensive Care, a prospective observational study. So in this study, my colleagues and I, we evaluated a total of 445 ultrasound examinations from 64 patients. And we could observe that the optic nerve sheath diameter demonstrated a strong correlation with intracranial pressure measured invasively. And also, we analyzed the ability of optic nerve sheath diameter to detect intracranial hypertension, specifying a threshold of intracranial pressure greater than 20 millimeters of mercury. And for this analysis, we could observe that this method presents a high accuracy to detect intracranial hypertension, and the best threshold in which we could detect intracranial hypertension was optic nerve sheath measured as 5.85 millimeters. And also, based on our 445 measurements, we could model the relationship between optic nerve sheath diameter and intracranial pressure measured non-invasively through a linear regression model. So in this case, we obtained this estimation formula that non-invasive intracranial pressure based on optic nerve sheath diameter is 4.7 times the measurement of optic nerve sheath diameter minus 12.35 millimeters of mercury. The second example I would like to highlight is this study entitled Ultrasound Non-Invasive Intracranial Pressure Assessment in Pediatric Neurocritical Care, a pilot study published on child's nervous system. So in this study, my colleagues and I, we analyzed 107 measurements of optic nerve sheath diameter measured with ultrasound and intracranial pressure measured invasively from 10 pediatric patients. And results from linear regression between optic nerve sheath diameter and ICP revealed a strong and significant relationship between these two parameters, as well as by performing a receiving operator characteristic curve analysis, we were able to demonstrate that using a threshold of 15 millimeters of mercury for determining intracranial hypertension in children, the optic nerve sheath diameter method had a high accuracy of 0.94, with the best threshold to determine this increases in intracranial pressure above 15 millimeters of mercury, as optic nerve sheath diameter measured as 3.85 millimeters. And now regarding the clinical applications in non-neurocritical care settings, in the next two slides I will highlight some of our previous works. But overall, the optic nerve sheath diameter has been applied vastly in other non-neurocritical care settings, for example, in intraoperative settings, for example, in patients undergoing metabolic coma, cardiac arrest after hypoxic ischemic brain injuries, septic shocks, and also in pregnant patients. So regarding the application of optic nerve sheath diameter in intraoperative settings, my colleagues and I, we had the opportunity to study this parameter in two different circumstances, and we were able to publish these two studies. So the first one was the evaluation of optic nerve sheath diameter during prone position and positive and expiratory pressure during surgeries, which are common procedures in several different types of surgeries. In the second study, we analyzed the effects of pneumoperitoneum and this surgical position, the Trendelenburg position, on intracranial pressure assessing using non-invasive methods, different methods, in a specific the optic nerve sheath diameter measurement. And finally, another example I'd like to highlight is the application of optic nerve sheath diameter in patients after cardiac arrest suffering from hypoxic ischemic brain injury. So in this condition, normally the patients cannot be monitored with invasive intracranial pressure, but in this study we were able to find a population in which we could apply this method and then compare with non-invasive techniques, which I will highlight in the next slide. So in this study entitled A Comparison of Non-Invasive versus Invasive Measures of Intracranial Pressure in Hypoxic Ischemic Brain Injury After Cardiac Arrest, we were able to analyze measurements of optic nerve sheath diameter measured through ultrasound and intracranial pressure measured invasively in these patients. And we were able to find a moderate relationship between these two parameters, although with high significance. Also, we were able to perform a prediction analysis to determine the best threshold to identify events of intracranial hypertension above 20 millimeters of mercury. And the best threshold for optic nerve sheath diameter we could observe was 5.95, which yielded an accuracy area under the curve of 0.9 to 6. And finally, I would like to end with some concluding remarks. First is that the dilation of the optic nerve sheath is a near instantaneous manifestation of raised ICP, which indeed can be captured with ultrasonography of the eye, therefore establishing this brain-eye crosstalk. Also, during the performance of the ultrasonographic measurements of optic nerve sheath diameter, please bear in mind of the pitfalls and limitations of this technique as I discussed previously, and also that optic nerve sheath diameter for the identification of intracranial hypertension events have been vastly studied in the literature, and by using a threshold of ICP greater than 20 millimeters of mercury, most studies have reported that the cutoff for detecting these events of intracranial hypertension should be between 5 to 6 millimeters. With that, I would like to conclude my presentation and open up to questions. Thank you very much for listening.
Hello to everybody. I'm Dr. Robba from Genova, Italy, and we are going to discuss in the next 15-20 minutes about the mechanical ventilation in brain injured patients. This is the agenda for the next minutes that we will spend together. As you can see, we will start discussing the pathophysiology, the clinical evidence then, and then we will have some time to discuss the mechanical ventilation strategies in real life, the ongoing research, and a bit of research agenda for the next year on this topic. So experimental evidence, it is pretty clear from both experimental and clinical evidence that there is a lung and brain crosstalk. And in particular, actually, it's not just a brain-lung crosstalk, it's a systemic and brain crosstalk, because every time there is a brain injury, there is also a dysfunction or anyway an effect on the peripheral system, which includes, for example, liver failure, kidney failure, infections, pituitary dysfunction, cardiological and respiratory complications. And in particular, when there is a initial cerebral damage, what happens is that this is a normal healthy brain with the astrocyte and the microglia here. And when we are in front of an injured patient, there is a disruption of a tight junction with infiltration of the macrophage, of the microglia and lymphocytes at the level of the brain, and loss of protection between the brain and the vascular system. And this causes a local inflammation, which then becomes a systemic inflammation. And this happens through different mechanisms, which the main ones are the vagal cholinergic reflex and the sympathetic reflex. And this causes systemic inflammation with activation of the cytokines, of the interleukins, endothelial cell injury with lung inflammation, and therefore the occurrence of lung injury. Also, our therapies can be detrimental for both the brain and the injury. In fact, when we treat the brain, when we treat, for example, intracranial hypertension, we can use drugs like the barbiturates, we can give the patients hypothermia, we can cause hypertension and hypervolemia, and these can further damage acute lung injury. And per se, brain injured patients are patients who have a higher risk of pulmonary complications such as pneumonia, VAP, neurogenic pulmonary edema, thoracic trauma, etc. So it's a sort of very difficult and complicated situation. This is an experimental and interesting study which was performed on piglet models here, who were monitored with intracranial pressure, and this is basically a model of acute intracranial hypertension. And what the Hoyer and colleagues found in this study is that intracranial hypertension can per se increase the quantity and the amount of extravascular water at the level of the lung, and that really per se can further damage brain function. The patients, the experimental models were divided in 4 groups: the control, patients with acute intracranial hypertension, experimental models with ARDS, and with acute intracranial hypertension. And as you can see here, in both the control and ARDS patients, the occurrence of intracranial hypertension was associated with an increase of the water in the chest. So per se, without any external causes, the occurrence, experimental induced, of intracranial hypertension cause lung damage. And on the other hand, in the group of ARDS, the occurrence and the presence of experimental ARDS was associated with an increase of NAC, which is a marker which is associated with a brain dysfunction and neuronal damage, and this was independent for the occurrence of intracranial hypertension. So important crosstalk, and this means that when we have a brain damage with a lung damage, we are really in trouble from a clinical point of view. Clinically speaking, we are in trouble because when peripheral organ dysfunction occurs after brain injury, the patients have a worse outcome, a very important increase of bad and poor neurological outcome, and an increase of a mortality. And in particular, the occurrence of pulmonary complications like ARDS is associated with an increase of mechanical ventilation days and ICU mortality and hospital mortality. Is it common? Well, this is a study that we have just published on neurocritical care just a few months ago. And we found that actually the occurrence of ARDS in subarachnoidal hemorrhage patients is not that common, at least is not as common as it used to be in previous evidence. We will discuss this in the next minutes. However, when it occurs, it is strongly associated with poor neurological outcome and mortality. And this is important because the presence of lung injury per se is associated with an increased mortality in patients with traumatic brain injury. And as you can see here, it is also associated with cerebral hypoxia. Cerebral hypoxia and systemic hypoxia are strongly correlated because there is a linear relationship between them. But if you can see the results from this physiological study that we performed with a group of Cambridge, when the PF is below 300, already there is a damage in terms of cerebral oxygenation. And the problem is that the concept and the threshold of at-risk cerebral oxygenation, it strongly depends by age, because, for example, in subjects which are younger, they can probably tolerate a lower threshold of PbTO2, of cerebral oxygenation, but in elderly patients, probably we need to increase even more the need for oxygen to the brain. And this is an important point, because this means that we need to neuromonitor the patients to individualize our treatment. Which is the state of the art? So the concept of protective lung ventilation has been established in ARDS patients, but which is the state of the art in non-ARDS patients, at least as the beginning, the first phase. This is one study, a randomized controlled trial of a PREVENT investigators, which compared tidal volume of 6 versus a tidal volume of 9 millimeter per kilo of predicted body weight, with a primary endpoints, which was ventilatory free days and mechanical ventilation days. So when we compare a low versus intermediate tidal volume strategy in patients without ARDS, there are no differences in terms of primary and secondary endpoints. So regarding ventilatory free days and days of mechanical ventilation, it doesn't really make any difference, as you can see here from this graph on the right. However, in the group with low tidal volume, the authors found higher frequencies of hypercapnia, of course, which was correlated with a longer mechanical ventilation days when the patients were intubated in the ICU, and a higher incidence of delirium. So be careful anyway to the hypercapnia or to the pH is maintained. Regarding the PEEP is still an open question probably, but this is a nice systematic review and meta-analysis of a randomized controlled trial which compared the low PEEP levels with high PEEP levels here. And as you can see from the pooled results, the use of high PEEP with these levels had no effect on the duration of mechanical ventilation, but it was probably related to a lower rate of ARDS. We are still talking about patients with initial no ARDS, so like a general brain injury patients. What we know in non-ARDS patients is that we need to be protective in terms of intrathoracic pressure. So the driving pressure, for example, is something that we need to keep in our mind. As long as we keep the driving pressure below a certain threshold, which is generally 15 centimeters of water, we reduce hospital mortality. But there is a linear correlation with the increase of driving pressure and hospital mortality. And the same is basically for the plateau pressure. So in both ARDS and non-ARDS patients, we need to be protective and keep a plateau pressure below a certain threshold in order to reduce the VILI and to reduce further lung injury. Which is the problem of applying this concept in brain injured patients? The problem is that brain injured patients have specific characteristics, and there are also concerns regarding the use of the protective ventilation and rescue strategies in these patients, because if you use low tidal volume, for example, this can cause hypercapnia, and this can increase intracranial pressure, and we don't want an increase of intracranial pressure in brain injured patients. On the other hand, the use of high PEEP or increased intrathoracic pressure, for example, for recruitment maneuvers or prone position, etc., can increase the intracranial pressure consequent to increased intrathoracic pressure. And this is, again, something that we don't want. So traditionally, brain injured patients have been considered a different group of patients in terms of principles of mechanical ventilation. And there have been a number of false beliefs, I like to call them, because now we are trying to make a more deep reasoning on this. But these patients were ventilated with ZIP, so with no PEEP. They were ventilated with very, very high tidal volume, like 10 milliliter per predicted body weight. These were patients where prone position, recruitment maneuvers, ECMO, and all the rescue strategies were completely forbidden and were not considered at all. And these patients have been considered excluded from the big trials where lung protective strategies have been tested, because the presence of acute brain injury was considered a contraindication for the use of lung protective ventilation. And in fact, when we are in front of both acute brain injury and lung injury, we are really in trouble, because we don't have any recommendation, we don't have any real randomized controlled trial, we don't have any evidence. And if you see the targets and the use of different recommendations for different rescue therapies and ventilatory strategies, sometimes the recommendation for the brain are exactly in the opposite way of those of the lungs. And even the respiratory targets, like the target of oxygenation and the targets of for the lung, are not really going in the same direction. For example, for the ERDS, a 55-80 millimeters of mercury of oxygen is probably enough. But if you have an acute brain injury, probably you have to keep your oxygenation higher than this. So what we should do when we are in front of a brain and lung injury? Well, what we know is that anyway, even in brain injured patients, the driving pressure and the protective strategies associated with low intrathoracic pressure are anyway useful. This is one of a few studies exploring the role of ventilator parameters and strategies in brain injured patients. And what they found here in this paper is that driving pressure is associated with the development of ARDS in a mechanically ventilated brain injured patients. So try anyway to be protective with, regarding the pressure. For the rest, we really don't have much evidence. But in the last years, we worked a bit asking to the physicians and to the expert, which is basically the state of the art. So in real life, what do neurointensivists do in terms of mechanical ventilation? This is a survey which was published like last year on critical care from the European Society of Intensive Care, and the respondents were asked to reply to several questions regarding the ventilator settings in 3 different scenarios: in patients with a PF above 300, between 150 and 300, and below 150. And as you can see from the results, the general idea that we got from this survey is that people are starting not to be so strict in the old false beliefs regarding brain injured patients. So brain injured patients are starting to be ventilated in a protective way with a low intermediate tidal volume, and that the people are not scared anymore about using high PEEP even in the presence of intracranial pressure, of course, if this is needed. And there is also another signal from this survey, which is that even the recruitment maneuvers, the prone position, and also the ECMO and the extracorporeal circuits are rescue strategies which at least should be taken in consideration and that are actually used. So see that they are not contraindicated anymore. This is what happens in the operating room. This is a secondary analysis from the Las Vegas study, which is a large observational study. And as you can see here, there are the ventilatory settings that are generally used in neurosurgical patients with brain damage. So if you have a look here, the tidal volume that was generally used was 8 milliliters per kilo predicted body weight, and no one of the responders of these centers use a ZIP anymore. And if you look at these scatter plots, where we considered the different ventilatory settings of PEEP, peak pressure, respiratory rate, and driving pressure in brain injured patients and non-brain injured patients, the ventilatory settings were basically not different in terms of intrathoracic pressure and respiratory rate between brain and non-brain injured patients. So it seems that in neurosurgery, brain injured patients are starting to be ventilated basically in the same way as in non-brain injured patients. What's happening in the ICU? This is an interesting paper which is going to come out on critical care medicine soon, including 3 different cohorts from 2004, 2010, and 2016. And what we analyzed were the changes in the ventilatory settings among these 3 cohorts. This is the tidal volume, for example. As you can see, over the years, there is a reduction of the tidal volume used in brain injured patients. In 2004, there was a large number, 30% of patients who used more than 10 milliliter per kilogram of predicted body weight, and these are much lower now, and protective ventilation is gaining definitely more interest. And the same is for PEEP. Increasing PEEP are being used over the years, but the interesting thing is that in 2004, still a lot of people used less than 5 centimeters of water of PEEP, and now just really a small number of brain injured patients in the ICU are ventilated with less than 5 centimeters of water of PEEP, and nearly no one with 0 of PEEP. And then we try to move forward, and we asked to the expert, the world expert, what do they do and what do they recommend in terms of mechanical ventilator settings. So we have created a panel of 29 experts from all over the world, and through a Delphi approach, we basically tried to give some recommendations. I have to tell you already that unfortunately there are no evidence, have a look here, in nearly no one of the demands that we try to address. And there is also a bit of lack of consensus on some important topics. But in some other, I think we can have some clinical information that could be interesting. So the first demand that we asked to the expert was regarding the indication of endotracheal intubation, and a strong recommendation was obtained regarding the indication for intubation. We should be guided from different factors, so a combination of factors, both respiratory factors and neurological factors, basically to protect the airway. The suggestion of the expert is not to weigh too much, because brain injured patients need a strict oxygen and carbon dioxide control, so don't weigh too much for the intubation. It is unclear whether the use of non-invasive ventilation can be safe and effective. Maybe for the NIVA, we still didn't get any recommendation, but we obtained a recommendation even 2 weeks regarding the use of high flow cannula oxygen, which can be actually considered a good option in acute brain injured patients. Regarding the ventilatory settings, we obtained a strong recommendation regarding the concept of PEEP, and basically the expert agreed that we should use the same level of PEEP that we generally would use in the general ICU population, and that if there are not important contraindications in terms of intracranial pressure, we still should use lung protective ventilation strategies such as low intermediate tidal volume and low plateau pressure and low driving pressure. However, when ICP is unstable, things are obviously a bit more difficult, and in these cases, when significant ICP elevation occurs, we did not find any consensus, and I think this is a very crucial point for future research. Target of oxygen. The target of oxygen for brain injured patients is higher than in those recommended for ARDS, so try to keep them between 80 and 120 of oxygen and aim to normocapnia. In case of brain herniation, consider the use of hyperventilation as therapeutic option. In case of intracranial hypertension, we did not obtain the consensus, but there are some other consensus and guidelines which suggest a mild use of hyperventilation and hypercapnia around 30 millimeters of mercury. Rescue therapies. Here we found a strong recommendation regarding the use of prone position, which actually should be considered, and for the neuromuscular block, whether no recommendation was found regarding alveolar recruitment or the use of extracranial extra systems like ECMO or extracorporeal CO2 removal. The risk with these two latter instruments is that they need a high amount of anticoagulation, and in brain injured patients, this can cause further bleeding and cerebral complication. Regarding the ventilator weaning and extubation, again, the concept is that you have to consider always the trajectory, the neurological status, the respiratory, all the respiratory factors. However, it's still unclear which is the neurological status which is enough to allow weaning and extubation. So which is the level of GCS which allows us to think that the patient won't fail the extubation. And regarding the tracheostomy should have generally, again, a whole consideration regarding the status, the neurological status and the trajectory of the neurological status of the patient. But the big question which is still ongoing is which is the perfect timing for performing a tracheostomy, early versus late tracheostomy. And in this, the expert did not find a consensus, and we recently published a paper on ICM with a center TBI group, and we found that basically there is a huge variability among centers and country, and this means that probably the guidelines are just local and it depends on local policies and the clinical judgment. The result from this consensus allowed us to write down a scientific agenda, which is extremely busy because, as you can see, there are no evidence at all in this group of patients, and now we need to push forward to answer to all the questions that are still pending in this group of patients. And we hope that the VentiBrain study, which is about to start, we are just waiting for the last details regarding the ethical committee approval. We have 184 centers, and this is going to be a large multi-center observational study where we will aim to assess basically the clinical practice regarding ventilation in brain injured patients and the occurrence of pulmonary complication in these patients. And we will make also some reasoning about subgroups with increased intracranial pressure or with pneumonia and ARDS. While we are waiting for the result of this, I just want to give you some clinical suggestions, clinical recommendations, which are based on the very few evidence that we have, on the consensus that we performed, and on our own clinical practice. So, as I was mentioning, regarding the intubation, consider that brain injured patients need early protection of the airway to prevent aspiration because they have poor neurological outcome, and that they need strict monitoring and targeting of oxygen and CO2. So don't wait too much for the intubation because you risk to have bad side effects. CO2 and oxygen target, avoid hypoxia, but also avoid hyperoxia, excess hyperoxia. Aim generally for normocapnia, and consider that hypercapnia can increase intracranial pressure. Hypocapnia, on the other hand, extreme hypocapnia can worsen cerebral perfusion. Regarding the tidal volume, try to be protective, try to reduce the plateau pressure and to keep the plateau pressure between 18 and 25 and to maintain a low driving pressure, minimizing the respiratory rate. Don't be too scared about the PEEP because if the hemodynamic stability is maintained with the PEEP, probably this won't have a big effect on the intracranial pressure. Recruitment maneuver, consider it case by case. In some cases, they can really help to improve the oxygenation, but again, be very careful with the hemodynamic status of the patient. And the same is for the prone position. It can actually improve oxygenation and it can actually improve cerebral oxygenation, but use it under a strict neuromonitoring. Regarding the other strategies, they should not be forbidden. So consider it case by case and consider the risk of bleeding and the risk of respiratory failure and hypoxia. So in some cases, ECMO has been, for example, used in brain injured patients without the initial bolus of heparin or with a half dose. So this should be considered in a multidisciplinary status. For the extubation, there are not specific scores in this population, taking consideration both respiratory and neurological factors. And for extubation and tracheostomy, try to have a long-term view to consider the neurological performance and trajectory of the patients and the clinical status of the patients. And the timing for tracheostomy, so far, there are not strong indications, so should be according to the local policies. I would like to thank you for your attention, and of course, I'm available for any questions that you want to ask me. Thank you very much.